Okay. Good morning. Today we'll be discussing about the surgeries of cataract as we have already discussed in the previous class. We'll try to see a few videos today. So you all know what are the types of surgical management of cataract. So basically there are two main types of surgical management of cataract. The first one is intracapsular cataract extraction, which is also called as ICCE. The second one is extracapsular cataract extraction, which is also called as ECCE. Okay. So, what are the benefits of surgical management of cataract surgery? The most important benefit which the person or the patient will be getting by undergoing a cataract surgery is visual improvement. This is the main reason for going for a cataract surgery. And sometimes there are some medical indications like lens-induced glaucoma has to undergo cataract surgery to reduce the glaucoma. Phacoanaphylactic endophthalmitis, where the eye is completely infective, where evisceration has to be undergone in those eyes, or else the infection can spread to the other parts of the body and can be fatal. And certain diseases like retinal disease, like diabetic retinopathy, where cataract is removed, so that application of laser will be a bit more easier to the surgeon. So that's why disease like diabetic retinopathy, cataract surgeries is advised, and sometimes cosmetic indication. So there are certain pre-operative evaluation which you're supposed to do to all the patients before undergoing any surgery. So the first is the general physical examination. You have to always take for the rule a history of any hypertension, diabetes, any history of CVA, any cardiac problems, or some like any history of TB, any history of steroid usage, and all we have to take. Steroid usage is commonly causes cataract in asthma patients. So that is why steroids use. We should know what is the etiology of the cataract. That's why we should always ask the proper history of the patient. Then we do the ocular examination, where thorough examination should be done under a slit lamp. So we should search for if there's any local infection. If there is any infection, we should first treat for the infection, and then once it comes down, then only plan for the surgery. And sometimes we should go see if the anterior segment thoroughly we should look, because sometimes there are certain things which can be missed out, like shallow anterior chamber and all, which can cause later complications in the patient's life. Intraocular pressure measurement is very important. Then there are certain retinal function tests which are supposed to be undergone, like light perception of light, a test for Marcus Gun pupils, projection of rays, two light discrimination test, Maddox rod test, color perception, entopic visualization, laser interferometry, and other tests like ERG. Okay, so what are the pre-op investigations according to the eye which you do is, first we should know what is the intraocular lens power which the patient will be getting. So to do that, we have a formula called as SRK formula, which is Sanders-Redzaf-Karpf formula, in which P is equal to A minus 2.5 L minus 0.9 K, where P is the power of intraocular lens. A is constant, which is specific for each type of lens. So each material has different type of A. Like PMMA material has different type of A. Silicon material has different types of A value. So each lens has a specific given value. L is the axial length of the eyeball in mm, which is determined by A-scan ultrasonography, and K is the average corneal curvature, which is determined by the keratometry. The ultrasound machine equipped with A-scan and IOL power calculation software is called as biometer. Okay, in this, the first graph which you can see is an A-scan, and the down one which you can see here is a B-scan. So we have, most commonly we have contact A biometry, where the patients undergo this exam test, and we have keratometry such as Bosch and Lomb keratometer. So what are the preoperative medications which are supposed to give to the patient is, topical antibiotics should be given. Preparation of the eye to be operated, like eyelashes of the upper lid should be trimmed. These days no one is doing that because we get ready-made sheets which protects the uh, eyelashes from preventing the field of surgery. An informed and detailed consent should always be obtained from the patient and the patient's attender. Scrub bath of hair should be done. To lower the IOP, usually Dimox, which is also known as acetazolamide 500 mg, is given 2 hours before the surgery, or intravenous mannitol 1 gram per kg body weight half an hour before surgery may be used. To sustain a well-dilated pupil, there is a combination of few drugs which are usually given, which is flupyprofen, tropicamide, and phenylephrine eye drops. These three should be given so that the dilatation is sustainable throughout the surgery. Coming to the anesthesia, ocular surgery may be performed under topical, local, or general anesthesia. Surface is also known as topical anesthesia, where anesthesia is achieved by topical instillations of 4% xylocaine. Use a drop of anesthetic solution instilled 4 times after every 4 minutes is sufficient to produce conjunctival and corneal anesthesia. So most commonly, all these phaco surgeries are done under the topical anesthesia. Even the refractive surgeries are done under topical anesthesia. Cataract surgery, facial block, these are the various types of blocks. These blocks are usually given for small incision cataract surgery. General anesthesia is given for patients who are uncooperative or children or any major injuries. Then that time general anesthesia is opted. So basically, as I've said, there are two types of cataract surgeries. The first one is intracapsular cataract extraction, and the second one is extracapsular cataract extraction. So in types of extracapsular cataract extraction, we have again three types. One is the conventional ECCE, second one is small incision cataract surgery, and third one is phacoemulsification. So the advantage of ECCE over ICCE is ECCE always has the advantage of putting an intraocular lens into the patient's eye, whereas ICC doesn't have that. ICC is an old technique which is now not being done by anyone. So conventional ECC has various steps. The disadvantage of conventional ECC is it requires a lot of suturing after the surgery, whereas a small incision cataract surgery and phacoemulsification are sutureless surgeries. So the main differences between ICC and ECC is ICC is easy to perform and less time consuming, whereas ECC is relatively difficult to perform and time consuming. ICCE can be performed below the age of 20 years as zonules are tough, whereas ECC can be performed at all ages. ICC cannot be performed below 20 years of age. Subluxated lens can be removed through ICCE. Through ECCE, it cannot be removed. PCL in the bag implantation is not at all possible in ICCE, whereas in ECCE it is possible. Procedure capsulotomy is not needed. Limbal incision is taken. Large incision is taken for delivery of the lens, whereas here a small incision is enough for the delivery of the lens. Vitreous loss may occur, whereas it is rare as posterior capsule is intact. Post-op complications after cataract in ICC are comparatively there is no chance. Like PCO, posterior capsule opacification, and all are not seen because the entire lens along with the posterior capsule is taken away. Whereas ECC often occurs and needs secondary capsulotomy. Anterior uveitis is rare, whereas it occasionally occurs. Retinal detachment is highly high in ICC, whereas it is insignificant. Cystoid macular edema is more frequent than in ECC. Astigmatism is greater due to bigger incision. So we'll try to see a video of cataract surgery now. Just give me a minute. Just give me a minute. I'll just try to play a video.